The fluorescent lights hummed their familiar 60-cycle tune above the billing office. As I stared at the denial code flashing on my screen, the same code that had appeared 37 times in the past month, each one signed off by Dr. Marcus Henley, our new chief medical officer. My fingers knew every keystroke of the appeal process by heart muscle memory earned from 8 years of navigating insurance mazes that most doctors couldn't decipher if their careers depended on it. Elena, a word. Dr. Henley's voice carried that practiced warmth that made hospital donors write bigger checks. I minimized the denial pattern spreadsheet I'd been building and followed him to his corner office where floor-to-ceiling windows overlooked the city's financial district. His diplomas from Johns Hopkins and Harvard covered one-wall credentials that apparently made everyone forget he'd only arrived 6 months ago. "I've been reviewing your appeal rates," he said, settling into his leather chair while I remained standing. 23% above hospital average. That's concerning. The fluorescent buzz seemed louder in here, competing with the soft hum of his executive air purifier. Concerning how insurance companies notice patterns. When one billing specialist files significantly more appeals than others, it raises red flags. He leaned back, fingers steepled. "We need team players, Elena. People who understand that not every claim deserves a fight." I felt the familiar weight of my badge against my chest, the one that had gotten me through security at 5 a.m. for the past 8 years, long before Dr. Henley knew this hospital existed. "I'm fighting the ones that medical necessity supports. Medical necessity is a judgment call. My judgment." His smile never wavered. "Going forward, I'd like you to run any appeals over $5,000 through my office first, just to ensure we're being strategic." The word hung in the air like disinfectant vapor. Strategic. "Dr. Henley, some of these denials are final." He stood signaling the end of our conversation. "I'm sure you understand." I understood more than he realized. I understood that in the past month, every single high-dollar appeal I'd filed had been for patients from zip codes east of the river, the ones where people worked 2 jobs to afford gas money. I understood that the 37 denials all carried the same curious timestamp, approved initially, then reversed within hours by administrative review. But what I understood most was that Dr. Marcus Henley had no idea I'd been building a database of his decisions since his second week on the job. Back at my desk, I pulled up the files I'd been secretly compiling. Mrs. Rodriguez, 73, diabetic, needed a specialized insulin pump. Denied. Patient can manage with standard twice-daily injections. Mr. Chen, construction worker with a herniated disc, needed an MRI to determine if surgery was necessary. Denied. Conservative treatment with physical therapy recommended. Then I cross-referenced these with approvals from the same time period. Mrs. Wellington from Beacon Hill approved for a cosmetic dermatology procedure coded as medically necessary skin lesion removal. Mr. Ashford from Back Bay approved for experimental hormone therapy that cost more than Mrs. Rodriguez's insulin pump by a factor of 10. The pattern was elegant in its simplicity. Poor patients got denied, wealthy patients got approved, and Dr. Henley was the only common signature on all the reversals. Elena. The voice belonged to Janet Holloway, the night shift supervisor, who'd trained me when I started here. She was carrying a stack of files, her usual Tuesday evening routine. "You staying late again?" "Just finishing up some appeals." Janet's expression tightened. "More denials from the new CMO." I nodded, then made a decision. "Janet, can I ask you something off the record?" She glanced around the empty billing office and pulled a chair closer to my desk. "Shoot. In your 15 years here, have you ever seen denial patterns like this?" I turned my screen so she could see the spreadsheet. Her eyes moved down the columns, patient names, zip codes, income estimates, based on insurance types, denial reasons, approval reversals. "Jesus," she whispered, "this is systematic." Janet was quiet for a long moment, studying the data. Finally, she looked up. "Elena, this could end careers, including yours, or save lives. You have any idea what you're up against? Henley's got the board eating out of his hand. He's cut costs by 12% in 6 months by denying care to people who can't fight back." Janet sighed, but she didn't argue. Instead, she pulled out her phone. "My daughter works in medical records, 3rd shift. If you need historical data, I might." "Be careful, Elena. Men like Henley, they didn't get where they are by playing fair." After Janet left, I stayed until midnight, pulling more files, cross-referencing more patterns. The fluorescent lights hummed their mechanical lullaby as I built my case one denial at a time. Wednesday morning brought a new wrinkle. Mrs. Rodriguez's daughter called, voice tight with panic. "Miss Castro, they're saying my mother's insulin authorization was denied again. The pharmacy won't fill her prescription without approval. She's been rationing her doses." My stomach clenched. Rationing insulin was a death sentence in slow motion. "Let me make some calls. Don't let her skip any more doses." I pulled up Mrs. Rodriguez's file. The initial approval had gone through automatically. Our system approved standard diabetes medications unless flagged for review. But 12 hours later, Dr. Henley had personally reversed it with a note. "Patient history suggests non-compliance. Standard insulin adequate." I'd read Mrs. Rodriguez's chart. She'd been compliant for 3 years. Her A1C levels were textbook perfect. The only thing that had changed was her zip code. She'd moved in with her daughter in East Haven after her husband died. I picked up my phone and dialed the CMO's office. "Dr. Henley's office, this is Patricia. This is Elena Castro from billing. I need to speak with Dr. Henley about Mrs. Rodriguez's insulin approval. It's urgent." "Let me check his schedule. He has 5 minutes at 2:30. 2:30. Mrs. Rodriguez had been without proper insulin for 18 hours. At exactly 2:30, I knocked on Dr. Henley's office door. "Come in." He didn't look up from his computer. "Ms. Castro, right about the Rodriguez case. Her daughter called. She's rationing insulin because of the denial." "I see." He finally looked up, that same practice smile in place. "And you disagree with my clinical judgment. I'm questioning the basis for reversal. Her compliance record is perfect." Dr. Henley leaned back in his chair. "Elena, may I call you Elena? I've been practicing medicine for 22 years. I've seen thousands of diabetic patients. Trust me when I say that compliance rates drop dramatically in certain demographics. Certain demographics, Ornmois. Older Hispanic women, lower income brackets. It's not personal, it's a statistical reality." The fluorescent buzz seemed to intensify. I felt heat rising in my chest. "Dr. Henley, Mrs. Rodriguez's medical records show what I need them to show." His voice was still warm, but there was steel underneath now. "Elena, I'm going to be frank with you. This hospital operates on thin margins. We can't approve every expensive treatment just because a billing specialist thinks it's medically justified. That's not your job." "Then what is my job?" "Processing claims efficiently, following guidance from clinical leadership, being a team player." He stood up. "I've been hearing concerning things about your attitude lately. Pushing back on denials, questioning medical judgment, filing excessive appeals." My badge felt heavy against my chest. "I'm following proper procedure." "Procedure is what I say it is." The mask was slipping now. "And if you can't accept that, perhaps you'd be happier somewhere else." I met his stare. "Mrs. Rodriguez needs her insulin. Mrs. Rodriguez will receive appropriate care based on my clinical assessment. That's final." I left his office with my hands shaking, but not from fear, from rage. Back at my desk, I pulled up Mrs. Rodriguez's file again and started drafting an appeal. Then I stopped. An appeal would go to Dr. Henley's desk. He'd already made his position clear. Instead, I opened a new browser window and navigated to the State Insurance Commissioner's website. There was a section on filing complaints about unfair claim denials. I started typing. While the complaint uploaded, I called Mrs. Rodriguez's daughter. "Ms. Castro, I'm filing an emergency appeal with the state commissioner. In the meantime, take your mother to the ER if her blood sugar spikes. They can't turn her away. But the bills, Irmas, let me worry about the bills." That afternoon, I made another discovery. Janet's daughter had sent over 5 years of approval, denial data, and the patterns were even more disturbing than I'd imagined. Under the previous CMO, denial rates were consistent across all zip codes. But in Dr. Henley's 6 months, denials in poor neighborhoods had increased by 340%, while approvals in wealthy areas had actually gone up. I was printing the analysis when my desk phone rang. "Elena Castro." "Ms. Castro, this is Attorney Jennifer Walsh from the law firm representing the Rodriguez family. I understand you've been involved in Mrs. Rodriguez's insurance dispute." My heart stopped. "I'm sorry, what?" "Mrs. Rodriguez was hospitalized this morning in diabetic ketoacidosis. She's in intensive care. Her daughter mentioned that you'd been trying to get her insulin approved." The fluorescent lights buzzed louder. "Is she okay?" "She's stable, but it was close." "Ms. Castro, I need to ask you some questions about the denial process. Would you be willing to speak with me?" I looked around the empty billing office. It was after hours, but I wasn't alone. I could hear the custodial staff moving through the corridors, their cartwheels squeaking against linoleum. Yes, I said, but not here. We met at a coffee shop 6 blocks from the hospital. Jennifer Walsh was younger than I'd expected, with tired eyes and a briefcase that looked like it had seen its share of battles. Mrs. Rodriguez isn't my only client, she said, sliding a folder across the table. I represent 4 other families whose insurance claims were denied by Dr. Henley, all from low-income neighborhoods, all for medically necessary treatments. I opened the folder. 5 photographs stared back at me, Mrs. Rodriguez, Mr. Chen, and 3 other faces I recognized from my denial database. Under each photo was a medical summary and a death certificate. 3 of them hadn't made it. Jesus. Mr. Patterson died of complications from untreated heart disease. Mrs. Kim's cancer metastasized while waiting for approval for chemotherapy. Mr. Brooks had a stroke while his hypertension medication was under administrative review. My coffee cup rattled against the saucer. I hadn't realized my hands were shaking. Ms. Castro, I need to ask you directly. Do you have evidence that these denials followed a pattern? I thought about my database, my spreadsheets, my 8 years of navigating insurance systems that Dr. Henley treated like a personal checking account. Yes. Would you be willing to testify? The question hung in the air like the smell of burnt coffee. Testify meant going public. It meant putting my career on the line, my reputation, my ability to support my family. It also meant Mrs. Rodriguez might get her insulin, and families like hers might not have to choose between medication and rent. Yes, Jennifer Walsh smiled for the first time since we'd sat down. Good, because I have a feeling we're going to need all the evidence we can get. Thursday morning, I arrived at work to find a memo in my email inbox. Staff meeting, conference room A, 9:00 a.m., mandatory attendance. Sent at 11:47 p.m. the night before. The conference room was packed. Billing staff, medical records, nursing supervisors, people I'd never seen in the same room together. Dr. Henley stood at the front next to a PowerPoint slide that read, "Efficiency through excellence." Thank you all for coming. He began, that practiced warmth on full display. As you know, healthcare costs continue to rise, and we must be vigilant stewards of both patient care and fiscal responsibility. I took notes mostly because it gave me something to do with my hands. Around the room, heads nodded at appropriate intervals. To that end, I want to address some concerning trends in our claims processing department. His eyes found mine across the room. It's come to my attention that certain staff members have been filing excessive appeals, questioning clinical judgment, and generally working counter to our cost containment initiatives. The fluorescent lights hummed above us. I kept writing, documenting his words with the same precision I use for insurance codes. Effective immediately, all appeals over $1,000 must be pre-approved by my office. Additionally, any staff member whose appeal rate exceeds department averages will be subject to performance review. Janet Holloway raised her hand. Dr. Henley, what about cases where medical necessity is clear, but initial denials seem inappropriate? Medical necessity is determined by qualified clinical staff, not billing personnel. I understand there may be some adjustment period as we implement these new protocols, but I'm confident everyone will adapt. The meeting ended with polite applause and nervous glances. As people filed out, Dr. Henley approached my desk. Elena, a word. This time I didn't follow him to his office. Whatever you need to say, you can say it here. His smile faltered slightly. I think you might be more comfortable discussing this privately. I'm comfortable here. A few heads turned in our direction. Janet lingered near the coffee station, pretending to refill her mug. Very well. Dr. Henley's voice carried that practiced authority, but there was an edge to it now. I've reviewed your recent work, and frankly, I'm concerned. Your appeal rate has increased by 40% in the past month. You seem to be questioning every denial that crosses your desk. I'm doing my job. Your job is to process claims according to established guidelines, not to second-guess medical professionals. I set down my pen and looked directly at him. Dr. Henley, in the past 6 months, how many of your denial reversals have been for patients from zip codes with median incomes above $60,000? The conference room went very quiet. Even the fluorescent lights seemed to pause their eternal hum. I beg your pardon. It's a simple question. I can pull the data if you'd like. His face flushed slightly. Elena, I think we should definitely discuss this in my office. No, I don't think we should. I opened my laptop and pulled up the spreadsheet I'd been building. Actually, I think everyone should see this. Janet moved closer. So did 3 other billing specialists who'd stayed behind to finish paperwork. Ms. Castro, you are out of line. Am I? I turned the laptop screen toward the small gathering. These are denial patterns from the past 6 months. Notice anything interesting? Janet leaned in first. All the high-dollar denials are from zip codes AIR2119, AIR2120, AIR2125, and AIR2128, east of the river. Predominantly low-income, predominantly minority. Dr. Henley stepped forward. This is completely inappropriate. I'm terminating this conversation immediately. You can terminate the conversation, I said, standing up, but you can't terminate the pattern. Elena Castro, you are suspended effective immediately. Security will escort you out. The small crowd around my desk exchanged glances. Janet stepped forward. Dr. Henley, with all due respect, Elena has been processing claims here longer than you've been at this hospital. If she's identified a pattern, Ms. Holloway, unless you'd like to join Ms. Castro in unemployment, I suggest you return to your duties. But Janet didn't move. Neither did the others. Dr. Henley said Maria Santos from medical records. My cousin is Mrs. Rodriguez. She's in the ICU right now because her insulin was denied. Elena tried to help her. Medical decisions are not made by billing clerks, but they're reversed by CMOs, I said quietly. 12 hours after automatic approval, every single time. Only for patients who can't afford to fight back. Security arrived 2 guards I recognized, men who'd nodded hello to me every morning for 8 years. They looked uncomfortable. Ma'am, we need you to gather your personal items. I packed my coffee mug, my photos, my emergency sweater. As I cleared out my desk drawers, I made sure everyone could see me pocket the USB drive containing all my data files. Elena, Janet whispered as security waited. Be careful. You too, I whispered back, all of you. As I was escorted to the exit, I heard Dr. Henley's voice behind me addressing the remaining staff. I hope everyone understands the importance of following proper channels and maintaining professional boundaries. The automatic doors closed behind me with a soft whoosh, cutting off the familiar fluorescent hum I'd lived with for 8 years. But I wasn't unemployed long. Friday morning, my phone rang at 7 a.m. Ms. Castro, this is David Kim from Channel 7 Investigative Reports. Jennifer Walsh gave me your contact information. I understand you have documentation of questionable insurance practices at Metropolitan Hospital. 3 hours later, I was sitting in a television studio watching my spreadsheets fill a 60-inch monitor while David Kim asked questions I'd been preparing to answer my entire career. So these denial patterns, they began when Dr. Henley arrived. 6 months ago, the previous CMO's denial rates were consistent across all demographics. Dr. Henley's are not. Can you explain what you mean by consistent? I pointed to the screen. Under Dr. Williams, the previous CMO denial rates average 8% across all zip codes. Under Dr. Henley, denials in low-income areas average 27%, while wealthy neighborhoods see a denial rate of 2%. That's a substantial difference. It's statistically impossible without intentional bias. David Kim leaned forward. Ms. Castro, you worked at Metropolitan for 8 years. In your professional opinion, what accounts for this dramatic change? I thought about Mrs. Rodriguez in the ICU, about Mr. Chen's untreated back pain, about the 3 death certificates in Jennifer Walsh's folder. In my professional opinion, Dr. Henley is running a 2-tier medical system. Rich patients get approved, poor patients get denied, and the hospital saves money by gambling that poor people won't fight back. That's a serious accusation. It's a documented pattern. The interview aired that evening. By Saturday morning, my phone was ringing every 10 minutes, other news stations, advocacy groups, families who'd been denied coverage. By noon, Metropolitan Hospital had released a statement announcing an internal investigation into recent concerns about claims processing procedures. By Sunday, the story had gone viral. Monday brought a call I hadn't expected. Ms. Castro, this is Barbara Chen, chairwoman of Metropolitan Hospital's Board of Directors. I'd like to schedule a meeting with you. The board met in a conference room I'd never seen before on the hospital's executive floor. 12 faces around a polished oak table with me at one end and Dr. Henley at the other. The fluorescent lights were softer up here, less industrial, but their hum was the same. Barbara Chen called the meeting to order. We're here to discuss the recent allegations regarding claims processing. Ms. Castro, you've made some serious charges. I opened my laptop and connected it to the room's presentation system. My spreadsheet filled the wall-mounted screen, 6 months of denials and approvals, sorted by zip code, income level, and medical necessity. These aren't charges, I said. They're documented patterns. Dr. Henley leaned forward. Barbara, this is highly irregular. Ms. Castro was terminated for insubordination and excessive appeals. She's clearly biased. Biased toward what? Crasum, toward undermining cost containment efforts. I clicked to the next slide, a map of the city with colored pins marking approvals and denials. The pattern was unmistakable: green pins clustered in wealthy neighborhoods, red pins concentrated east of the river. Dr. Henley, can you explain this geographic distribution? He shifted in his chair. Medical necessity varies across different patient populations. Compliance rates, follow-up care, lifestyle factors, all these influence treatment decisions. So you're saying poor people need less medical care? I'm saying clinical judgment must account for multiple factors. Barbara Chen studied the screen. Dr. Henley, these denial rates in low-income areas, they're significantly higher than our historical averages. We've tightened our review process to eliminate unnecessary treatments. Mrs. Rodriguez's insulin was unnecessary. The room went quiet. Dr. Henley's confidence flickered. That case is being reviewed. By whom? My office. I clicked to another slide. Mrs. Rodriguez's case isn't isolated. In the past 6 months, 37 patients from low-income neighborhoods were denied medically necessary treatments that were initially approved by our automated system. All 37 reversals were personally signed by Dr. Henley. Board member Thomas Wright raised his hand. What's the comparison for wealthy neighborhoods? 0 reversals. Automatic approvals stood without exception. The silence stretched for 30 seconds. Finally, board member Sarah Mitchell spoke up. Dr. Henley, can you walk us through your decision-making process for these reversals? Each case is evaluated on its individual merits, considering the patient's overall health profile, compliance history, and treatment outcomes in similar demographics. Similar demographics. Dr. Henley's face reddened slightly. Patients with comparable socioeconomic profiles. I clicked to my final slide: mortality rates. In the 6 months since Dr. Henley implemented his new review process, patient mortality rates in low-income zip codes have increased by 18%. In wealthy neighborhoods, mortality rates have decreased by 3%. Barbara Chen leaned back in her chair. Dr. Henley, how do you explain this disparity? Multiple factors influence mortality rates. Diet, exercise, environmental conditions, genetic predisposition. Poor people dying more because rich people are getting better care. I said quietly. That's an oversimplification. Is it? Enum. Dr. Henley stood up abruptly. Barbara, this entire proceeding is inappropriate. Ms. Castro was terminated for cause. Her accusations are clearly retaliation for disciplinary action. Dr. Henley, please sit down. He remained standing. I've brought this hospital's costs down 12% in 6 months. I've streamlined inefficiencies, eliminated waste, and implemented evidence-based protocols. If this board wants to abandon fiscal responsibility because one disgruntled employee— Dr. Henley, Barbara Chen's voice was sharp. Sit down. He sat. She turned to me. Ms. Castro, in your 8 years at Metropolitan, did you ever see patterns like this under previous administration? Never. And in your professional opinion, what would explain the current patterns? I looked around the table at 12 faces, some skeptical, some concerned, all waiting for an answer that could end Dr. Henley's career or mine. In my professional opinion, Dr. Henley has been systematically denying care to patients who can't afford to fight back while approving expensive treatments for wealthy patients who might take their business elsewhere. The result is a 2-tier healthcare system that prioritizes profit over patient welfare. Dr. Henley's laugh was bitter. That's absurd. Is it? I pulled out my phone and opened a voice recording app. Dr. Henley, would you mind repeating what you told me on Tuesday about certain demographics and compliance rates? His face went pale. I never said— I pressed play. Dr. Henley's voice filled the conference room. Older Hispanic women, lower income brackets. It's not personal, it's statistical reality. Silence was absolute. Barbara Chen looked at Dr. Henley with an expression I'd never seen before: professional disappointment mixed with personal disgust. Dr. Henley, you're suspended pending a full investigation. Security will escort you out. Barbara, you're making a mistake. This hospital needs fiscal discipline. What this hospital needs is medical ethics. 2 security guards appeared. The same 2 who'd escorted me out 3 days earlier. They didn't look uncomfortable this time. As Dr. Henley was led away, he turned back toward the table. You'll regret this. All of you. After he was gone, Barbara Chen addressed the remaining board members. I'm calling for an immediate external audit of all claims processes, a review of every denial from the past 6 months, and implementation of new oversight protocols. She turned to me. Ms. Castro, I'd like to offer you your job back with a promotion to claims review supervisor and a mandate to rebuild our approval processes from the ground up. The fluorescent lights hummed their familiar tune. I thought about Mrs. Rodriguez still in the hospital but stable now. I thought about the families who'd lost loved ones to delayed care. I thought about 8 years of navigating systems designed to help people, systems that worked when they weren't corrupted by bias and greed. I'll need a team, I said. Do whatever you need. And direct reporting to the board, not through the CMO's office. Agreed. And every denial over $1,000 gets reviewed by a committee that includes patient advocates. Barbara Chen smiled. Ms. Castro, I have a feeling you're going to be good at this job. 6 months later, Metropolitan Hospital's denial rates were consistent across all zip codes for the first time in years. Patient mortality rates had dropped to historic lows. Mrs. Rodriguez was home with her family, her insulin pump fully covered and functioning perfectly. Dr. Marcus Henley had been fired and was facing investigation by the state medical board. The hospital had settled lawsuits with the families of patients who died waiting for care and had implemented new training programs on bias in medical decision-making. I kept my old desk in the billing office, even though my new role came with an offer of a private office. I liked the fluorescent lights, their steady 60-cycle hum, a reminder that some things like doing the right thing never go out of style. On my desk next to my coffee mug and family photos, I kept a small frame printout of the final slide from my presentation to the board. It was a simple bar chart showing denial rates before and after our reforms, consistent across all demographics based on medical necessity rather than ability to pay. Janet Holloway stopped by my desk every Tuesday evening, just like old times. We'd review the week's cases, looking for patterns, making sure the system was working the way it was supposed to. Elena, she said one evening, you realize what you did right. You took on a doctor with Harvard credentials and a board that loved him for cutting costs. I looked at my screen where Mrs. Rodriguez's latest approval was processing automatically insulin pump supplies, fully covered, no questions asked. I didn't take on anybody, I said. I just kept doing my job. The fluorescent lights hummed their agreement, a steady reminder that sometimes the most important battles are fought not with grand gestures, but with spreadsheets, voice recordings, and the quiet persistence of people who refuse to let the system forget its purpose. 3 months after that, I received a call from the State Insurance Commissioner's office. Ms. Castro, this is Director Patricia Williams. We've been reviewing similar patterns at hospitals across the state based on the methodology you developed at Metropolitan. We'd like to offer you a position as Director of Claims Equity Review. What would that involve? Traveling to hospitals, statewide training staff to identify bias in claims processing, implementing oversight systems, essentially making sure what happened at Metropolitan doesn't happen anywhere else. I thought about all the Mrs. Rodriguez's out there, rationing medications they couldn't afford, choosing between treatment and rent money, dying, while wealthy patients got approved for procedures they didn't need. When do I start? A year later, I stood in the state capitol building, testifying before a legislative committee about a bill that would require all hospitals to track denial patterns by demographic and make that data publicly available. The committee room was packed with patients, doctors, insurance executives, and reporters. The solution isn't complicated, I told the legislators. Healthcare decisions should be based on medical need, not ability to pay. When we create systems that work differently for different people, we're not providing healthcare, we're rationing it based on wealth. The bill passed unanimously. 2 years after that, I received a letter that made me cry in a Starbucks in downtown Hartford, where I was training a new team of claims auditors. Dear Ms. Castro, it read, my name is Maria Rodriguez, and I wanted to thank you for saving my mother's life. She died peacefully at home last month, surrounded by family. She lived 2.5 years longer than the doctors originally expected because you made sure she got the insulin she needed. I know you probably helped a lot of people, but I wanted you to know you helped mine. Thank you for fighting for people like us. The letter was handwritten in careful script with a photo enclosed Mrs. Rodriguez at her 75th birthday party, smiling surrounded by 3 generations of family. I kept the letter in my briefcase, pulling it out whenever I felt discouraged by resistance from hospital administrators or insurance companies who preferred the old ways of doing things. The photo lived on my desk wherever my desk happened to be that week, because the work never ended. In every hospital in every state, there were billing specialists who could read insurance codes better than the doctors who ordered them. There were patterns waiting to be discovered, voices waiting to be heard, systems waiting to be fixed by people who understood that healthcare wasn't a privilege to be rationed by wealth. It was a right to be distributed by need. The fluorescent lights in every hospital hummed the same 60-cycle tune, a constant reminder that some things like fairness, like compassion, like the radical idea that all patients deserve equal care, never go out of style. And in billing offices across the country, people who understood systems better than the executives who ran them continued to fight for families they'd never met armed with nothing more dangerous than spreadsheets, voice recorders, and the stubborn belief that doing the right thing was always worth the risk. The work continued, the lights hummed on, and somewhere in a hospital billing office, much like the one where I'd started another Elena Castro, was building a database tracking patterns, getting ready to ask the question that would change everything. Have you noticed anything unusual about these denial rates? The answer, as always, was yes.